My presentation will cover a brief background. We'll talk about the reported COVID numbers, and then I'll get into why we're estimating excess mortality. We'll also discuss the data that are available and that are used as input into this work. We have a technical advisory group that supports the methodology, so I will briefly explain their terms of reference. And then we'll get into the nuts and bolts, the model framework that we're using to estimate the full impact, which has two components, an expected deaths component and a predicted deaths component. And then we'll have a very brief discussion afterwards. So as of April 8th, today, there are over 490 million confirmed COVID-19 cases and over 6 million reported COVID-19 deaths that have been reported to WHO. The reported deaths have been concentrated in 3 of the WHO regions. So 44% the region of the Americas, 32% Europe, and 13% in Southeast Asia. We can also look at the income group slice of that, and we have the reported COVID-19 deaths concentrated in upper middle income economies and high income economies. So that's 44% and 39% respectively. The challenge is that these reported COVID-19 numbers do not give a complete picture of the impact of the pandemic. So there's a number of reasons why we cannot rely just on the reported COVID-19 numbers. So these reported numbers miss the unreported COVID deaths. So across countries, there have been variations in access to testing, variations in diagnostic capacity, and even variations in how COVID-19 deaths are being defined. The reported COVID-19 deaths also miss increases in other deaths. So this is what we can call collateral damage that is linked to the conditions that have prevailed since the pandemic began. So this is, some countries have had overwhelmed health systems, some patients have avoided healthcare, and so on. So excess mortality is a crucial metric for comprehensively quantifying the impact. So when we talk about excess mortality, this is simply defined as the number of additional deaths for a specified location and time period if you compare those that are occurring to those that were expected to occur in the absence of the pandemic. So we have the expected deaths in the absence of the pandemic, and then we have those that are actually occurring. And the difference between those two are excess deaths. And we're talking about all-cause deaths in this case. The challenge is that timely, reliable, and complete data for estimating excess are limited. So only a subset of countries have the complete electronic medical certification and fully functioning civil registration and vital statistics systems. There is an observed lag of over a year after the end of a calendar for countries to submit cause of death data to WHO. And then attributes such as sex and age are missing from most of the data that are coming from countries. And these are necessary inputs when we're looking at the global health estimates, which are trademark outputs from the WHO, and also the World Population Prospects, which is an output from the United Nations Population Division. Ideally, we would want to, for every single country, be able to use their current data to estimate excess mortality. But as I've mentioned before, timely, reliable, and complete data are not available for all countries. What I'm showing in this map here is the distribution of data availability. So in the dark purple, those are countries that we're calling tier 1. So those are countries for which we have complete data for the entire period, and we're able to use that directly. Then we have the tier 2 countries, which are countries that have some data, but it's partially complete. So perhaps they have some subnational data instead of complete for the entire country, or it's only for a period. And then we have these countries which are calling tier 3, which do not have any data on all-cause mortality for the period of the pandemic. So looking at the regional distribution, that's the far right, the table, this tabulates what's shown in the map. So for the Africa region, 87% of countries do not have all-cause mortality data for tracking excess directly. So there's a wide range in this, with Africa region having the most gaps, followed by we have Western Pacific region, Eastern Mediterranean, and Southeast Asia, which also have significant gaps of over 50%. However, the European region, only 2% of the countries are missing data for us to be able to track excess. In order to tackle this problem, the WHO, in partnership with the United Nations, have convened a technical advisory group. So this, the purpose of this group is to advise on the best data sources and the best methodology to track excess mortality. So this tag is comprising of over 60 participants, 31 being members and over 30 being observers. It has a global and multidisciplinary expert representation. So we have experts in epi, data science, analytics, statistics, biostatistics, demography, and we also have representatives from national governments, academia, and some policy makers. And as I said, the purpose of this tag is to appraise the current approaches to measuring excess mortality, and then to develop a comprehensive and pragmatic set of measurement methods that we can use to track excess even in countries that do not have data, and also to provide guidance to countries for estimating the global toll. So that's the background. What I'm going to do now is just very quickly go through the methods and discuss what we are doing in the places with data and also in the places without. A very brief discussion after that. So for the places with all-cause mortality data, we've derived the expected deaths using the historical mortality that's available. So in terms of the symbols here, if we will represent the all-cause deaths for a particular country C and a month T, using the capital letter Y there. So we will let, for each country, this Y subscript C and T represent the all-cause mortality count for that country and for that month. So what we've assumed is that this YCT follows a negative binomial distribution. So you'll see all the methods that I described here are supervised methods for statistical analysis. So we assumed that this Y, these observed all-cause mortality data follow a negative binomial model, which are parameterized with a mean parameter mu and a scaling parameter phi. So this scaling parameter allows us to basically allow for the variance to differ from the mean and over dispersion parameter. So the way that we're predicting this mean parameter, this log, we're using a log linear model, which has two components. The first component is an annual trend, which we're representing here with F and subscript Y, and then a smooth function of time and month, which we're representing with F superscript M. And this allows us to model the within year seasonal variation that is occurring in the all-cause mortality. And we're modeling this using a penalized cyclic cubic regression spline. So to illustrate, let me take another country here. We use Belgium as an example. So what we're basically doing is historically, so this is an example historically from 2014 to 2019, we essentially have reported all-cause mortality data. We take those data and then we parameterize it for the annual and the monthly variation within a negative binomial framework. The goal of this is to forecast the expected trend into the pandemic period. So you can see in this plot, just take it forward maybe to 2019. So what we have in this plot, the green, those are your expected deaths coming from your negative binomial model. The peach represent, if you just take the reported COVID-19 numbers and you add them to the expected numbers, what do you get? And then the purple, those are your reported numbers. So this is an example. Belgium can do something similar, say for South Africa. And you can see the reason why we rely on excess mortality is that there can be a very significant difference between what has been reported and the expected number. So if we adjust to use the reported numbers, we can significantly undercount the true impact of the pandemic. So this model is trained on the location-specific data for the period 2015 to 2018. Then we calibrate it to minimize the root mean square error for 2019. And we use the calibrated model to then predict the expected deaths for all years from 2015 to 2019 to 2021. So the approximate simulations from the Bayesian posterior density of this model are used to generate the 95% credibility intervals. So this is the model for the places with data in 2020 and 2021. Now, for those countries that I showed in yellow, the places without data, we have to predict the all-cause mortality for the period. So we're using, again, these over-dispersed type of Poisson models similar to the negative binomial. And in this case, I'm introducing, in addition to the capital letter Y, we have a capital letter E. So these are the deaths that are expected in 2020 in the absence of COVID-19. So for these countries, we're fitting using the data from the countries with data, we fit an over-dispersed Poisson model of that form. So we have our all-cause mortality as a function of the expected deaths and a relative rate parameter theta. So this theta just tells us how we can scale the expected deaths to get the actual deaths within the pandemic. And we're modeling that relative rate parameter. So the relative rate parameter is modeled within a log linear model, and really there's two types of variables that we're using to predict this relative rate. There's time varying covariates. So these are things like the reported COVID-19 mortality rate, the test positivity rate. So out of the total number of people tested, how many cases are estimated. And then we have containment measures. So these are lockdown measures, closure of schools, mask wearing, and we have quantities to capture that. So we allow these to have associations with the relative rate in the places with data. Then we have some time invariant covariates, which are basically characteristics for the country. So these are things like the high income, whether or not it's a high income country, the social demographic index. So this is a composite index similar to the Human Development Index. It's made up of your log GDP per capita, your education, your fertility rate. So these are, you're able to create a composite measure there in the SDI. Then we have diabetes prevalence, cardiovascular mortality rates. So these are your comorbidity levels, and we use those within the model as well. And we assume that these have a constant association with our relative rate parameter. So we fit all of this in a Bayesian framework using INLA, so our INLA package, and we also use the penalized complexity priors in the modeling. I'm not going to go in depth into the results. This is just a map that shows the cumulative excess death rates for the for the entire period up to the end of 2021. And we do see that there are a few places, Australia, New Zealand, where we're estimating very low excess mortality. The places in red, those are the places with high excess mortality. And just in general, for the period, there's about 5.4 reported COVID-19 deaths, and we're estimating over 15 million excess deaths globally. So that is a ratio of about two to three times higher excess than reported COVID-19. The places in yellow, there are many of the countries for which we're predicting excess mortality using this regression model. So to wrap it up, let's just summarize. Your reported COVID-19 numbers give an incomplete picture due to data quality issues, and excess mortality is a more comprehensive, comparable, and objective measure. There are many countries that lack the requisite data to estimate excess mortality, so statistical models are necessary for us to do so. There are limitations in the modeling, so we know that every model is an approximation of reality. In addition, we have to contend with the quality of the inputs. That's the accuracy of the expected deaths, the completeness of the all-cause mortality, and also the consistency of the covariates, the way that they've been measured or defined across countries for us to be able to use them within the model. We're also contending with the generalizability of the effects, both in space and time. We're making some very strong assumptions to be able to generalize what is measured in a certain subset of countries and extrapolating it to countries that might systematically be different, both in the way that these covariates interact with the outcome and also in the way that that interaction changes in time. We're also looking at the sensitivity of the periodicity. So we're looking at expected death by month, but we know that even within weeks or days, that the way that the pandemic has been evolving has been dynamic. So we will continue to work with member states to update the data that are used as input and the models that are being applied so that we can stay abreast with the full impact of the pandemic. So I'll stop sharing here. Thank you for your time.